Hello, my name is Solome Tibabu. I'm the host of the Going Digital Behavioral Health Tech Conference. I'm really excited to have the Equip team here with us, as well as Optum, one of their partners. So to get started, maybe we should just do some introductions. Why don't we go with Kristina, Dr. Parks, and Dr. Rosenzweig.
Fantastic. Hi, everyone. Really thrilled to be here for the second year of the Going Digital Behavioral Health Summit. My name is Kristina Saffran. I am the co-founder and CEO of Equip. I've been working in eating disorders for basically my whole life. Was diagnosed with anorexia at 10 years old, struggled throughout my adolescence. At 15 in my recovery, started a nonprofit, Project Heal, to raise money for people who couldn't afford treatment. And really the catalyst for moving over to Equip was seeing over the last 2 decades that our research has improved dramatically. We have evidence-based outpatient treatments that work, and it was really horrifying to see that those were not making their way to the community and getting to people. So after years of plugging holes in a broken system, said, think we know the system, it needs to exist, and think we just need to build it. And Erin was the first person I called.
Yes, I'm glad you did. So I'm Erin Parks. I am a clinical psychologist by training. I spent the last decade as a faculty member at UC San Diego in the Department of Psychiatry and helped to run their eating disorder program. And Kristina and I had seen each other at eating disorder events over the past, many years. And when she was talking about the financial access issue, I was really concerned about the physical access issue. There are a lot of people who have great insurance or have the financial means to pay for treatment, but they were traveling from all over the United States to get care at the academic medical center I was at. And so I started thinking about, why is the evidence-based treatment not getting out into the communities, and how can we change that? And so we thought, nonprofit wasn't capitalized enough, and academia wasn't risk tolerant enough. And so we went the VC space and formed Equip.
And I'm Martin Rosenzweig. I'm the Chief Medical Officer with Optum, which is part of United Health Group.
Excellent. Why don't we start with Kristina? Can you tell us a little bit about what Equip is?
Yeah, of course. So we are on a mission to ensure that every single person with an eating disorder can access gold standard care. Want to take a step back for a second to just ground us in why this conversation is important. So we know that 5 million Americans struggle with an eating disorder each year. It's 30 million over the course of a lifetime. So that's 10% of the population. There's a horrible misconception that this is a rich white girl vanity issue, only affects people who look like me, when in reality, we know that eating disorders affect folks pretty equally across race, class, ethnicity. A third of sufferers are men. Most people with eating disorders are not underweight. You really can't tell just by looking at them. As a level of food insecurity rises in a community, the levels of eating disorders directly rise. And unfortunately, right now, only 20% of folks get treatment for their eating disorder, though they are getting treatment for other medical and psychiatric comorbidities. And of folks who get treatment, only 1% gets treatment that actually works. And so that is why we started Equip, to ensure that people had access to care, and not only access to any old care, but really access to care that works. And so the leading evidence-based treatment is called family-based treatment, really based on our understanding of the genetics and neurobiology of eating disorders, that really tells us that it's not that individuals with eating disorders are choosing not to eat and engage in pro-health behaviors, it's that their brains really aren't letting them, and that we need to bring in supports around them to make sure that treatment is really effective. And so we do that. We deliver what we call family-based treatment plus, based on our learnings from 15 years of working with thousands of patients and families on what was missing from their treatment experience. And we deliver it fully virtually, which we can talk about in a bit. That has been a really, really exciting thing to see, that we believe that virtual really is the way to go for eating disorder care.
How exciting. And Martin, can you talk a little bit about what was the situation with approaching eating disorders prior to partnering with Equip at Optum?
So eating disorders have been an issue for us as a payer for a long period of time. And I think there are a couple of things that we really struggled with. So even though this is only a small percentage of all of our members that end up in care, relatively speaking, they're expensive, because they end up in care for a protracted period of time. And they also had a very high recidivism rate. So they would go for treatment, typically in residential settings, very expensive, and then they would come home and things would fall apart again, and they really need to sort of cycle back. And we would often see these cases really over a period of years, where they would incur these incredibly high costs with very little sort of outcome, to show that it was, that we were really helping them. The other piece that I think was key is, remember, we're trying to make sure that there's a continuum of care. So we may identify someone, typically they would go to destination treatments, a residential, which may be hundreds, if not thousands of miles away from where they live. A key element, as Kristina mentioned, around treating eating disorders successfully is involvement of the family. So having a weekly phone call, or twice a week phone call, this is before the days where telemental health was sort of so popular, really doesn't cut it. And the family involvement was superficial at best. So so that was sort of part of the issue as well. The other piece is, lots of patients live in what I call sort of treatment deserts. There really is no specialized care in proximity to them, to work with providers that are actually trained in what works in eating disorders. So what would happen is they would, gain weight, they would sort of get on the right track at a residential setting, go home, and we couldn't find them providers because they just didn't exist. Or there would be great inconvenience for the family, to sort of have to travel great distance, and things would again fall apart. And I think the third piece over here as well is, that we, I think, really found difficult to treat an eating disorder patient successfully, particularly, with anorexia. You really need a team of 5 individuals. You need a therapist, you need a family therapist, you need a pediatrician, you may need a psychiatrist and a nutritionist. And for us to sort of pull together a team that could really meet the needs of that patient was extremely challenging. As you're coordinating care between 5 people and making sure that they talk to each other was just sometimes impossible. So, I've been interested in eating disorders since I was a resident. And part of it was really, how could you help these group of individuals? They had so much potential, and if they could just get the right care, they really could have a different life trajectory. When I started to work within United, really got to see that this was a national problem. So that's sort of what things look like. And to some extent, I think that's still true within the treatment environment. We still struggle with some of those same issues.
The space is definitely ripe for a lot of change and innovation, which, speaking of which, perhaps Erin, if you could weigh in, how has Equipped evolved in the last year?
It's been an exciting year, Salome, since we last were here at the conference. Right after we wrapped the conference with you last year, we were going into our beta trial. So we knew that all the different aspects of Equip had been tested in randomized controlled trials. But as Kristina likes to say, we never baked it all together in one pie. So we spent the summer doing beta trials, which have now been published. We're also presenting them next month at the Academy of Eating Disorders, showing that evidence-based treatment for eating disorders can be effectively delivered and have really positive outcomes in this virtual model and also in this team model. I think the next really big thing we did at Equip was hire these providers that Dr. Rosenzweig was talking about. So we hired our dietitians and our family mentors and our peer mentors and our pediatricians and our child and adolescent psychiatrists and our therapists. And it has been really fun putting together truly diverse teams. As Kristina mentioned, eating disorders affects everyone. So it's been wonderful getting to hire providers who identify as trans, because we know that the trans population is affected by eating disorders at a higher rate. Hiring male providers, hiring providers in higher weight bodies, and getting to watch our families get to interact for the first time with providers that really have been through their lived experience. For instance, we have a family mentor who was homeless when she had helped her child get through an eating disorder. So as we move into under-resourced populations and work on our Medicaid and Medi-Cal partnerships, we know what it's like to not only treat people who are under-resourced, but we also have family mentors who've truly been there. I think the other big thing that happened this year is just turning on and going live. So we're now live in 4 states, New York, New Jersey, Texas, and California. We've gone live with Optum. We're also in network with a handful of other payers, with many more payers coming. We also did a fundraise. So we closed our Series A in the past year and in the past couple months, and we're excited to use those funds to expand into even more states, to work on some more partnerships. And we're really eager to get more Medicaid and Medi-Cal partnerships going across the whole country so that truly everyone has access to evidence-based treatment.
That's just remarkable. Amazing. Congratulations. Kristina, this is the Going Digital Behavioral Health Tech Conference. Can you talk a little bit about what the tech platform is like?
Yeah, it's a great question. And I will say that, we say loud and clear that we are a services company enabled by technology. And it's really, our ability to really solve some of the issues that Martin was talking about in putting together a strong outpatient care team that we wanted to solve with partially our tech platform. And also Aaron talks a lot about, we see ourselves as a service for not only patients and families, but really for providers. And we have made it really hard for them to do their jobs in the traditional treatment landscape with the existing tech. And so we've built our platform to really think about how can we ensure that our providers are best equipped to serve their patients. And so we've built out all HIPAA compliant, our own messaging function. So all the care team members, this 5-person care team that we have, can message with one another, about how to best help the patients and families. They can message with the families, with the patient, one-to-one. Outcomes tracking is incredibly important for us. We'll go into this in a little bit, but really ensuring that we are collecting outcomes and then meaningfully using those outcomes to inform the care that we're delivering. Aaron talks a lot about, a lot of providers don't come into this profession because they love numbers and math, but we want to make them really good at being data-driven providers, whether they know it, whether they like it, to ensure that we're really using those outcomes to inform the care that we're delivering, and then transparently sharing it back with the payers as well, which I think Martin will get into. And then finally, something that I just think is so exciting is that Aaron and I started building this pre-COVID, right? And it was always going to be 100% virtual because access is really our North Star. And it's hard enough to find in-person treatment teams in New York City, in San Francisco, let alone more rural places of the country. But we probably would have told you 2 years ago, like, if you can find an in-person treatment team, it'll be hard, but you should do that. It'll be better. And we have totally changed our tune since seeing our first almost 100 patients now. And I think it's for 3 primary reasons. So one, I talk a lot about, you can't build a life worth living if you're not living life. And unfortunately, a lot of our existing treatment landscape takes people out of their lives and don't allow them to develop things to drown out their eating disorder. 2, it's a lot of appointments, right? I mean, imagining shuttling back and forth in a city with traffic to multiple appointments per week, especially for working parents with other kids, it can be a real hassle. And then 3, perhaps most exciting to us, is that this virtual treatment approach has really allowed families to bring their entire village to treatment. And this is so important because treatment is really, really hard work. We're often tasking families with feeding their adolescents 3,500 to 4,000 calories a day, every single day, to meet the recommended 1 pound of weight gain per week. And these adolescents have eating disorders, so they're fighting the entire time of it, right? And so treatment really does work best when you can bring in multiple family members. When I was going through my own treatment, it was rare that both my parents could come because they both worked. Now we have 2 dads who are construction workers who Zoom in from the sites. We have families bringing in, aunt and uncle and grandma and grandpa, and it just really, really does help with treatment outcomes. So we've been really, really buoyed by how we've been able to use the platform to really contribute to better treatment outcomes.
Super interesting. Now, Martin, why did you choose to work with Equip?
It's a great question. So, this is probably going back 2 years when we sort of, first started to speak. And there were a couple of things that sort of impressed me. The one was they had a very clear mission. They knew who they wanted to treat, how they wanted to treat them. Needed some help about, how they would sort of structure and sort of find solutions. But that was the first thing, was clarity of purpose. They knew, and coming to us with that sort of solution. The second thing was they really, from the get-go, wanted to work within the structure of insurance. So put together a program, that could be covered. It really wasn't trying to design something that would only appeal to a particularly wealthy part of the population. They really wanted to treat everyone, which is part of our mission too. The third one was, to their credit, is they really wanted to get feedback. So they weren't coming to us and, sort of dictating terms, if you want this, there was that flexibility in terms of sort of, understanding some of the limitations we have from a, regulatory or benefit structure point of view. Remember, as an insurer, we are representing our customers as well and what their benefits can support. So they heard that, sort of loud and clear. And I think that was the other, piece around that. And I think the most important thing was they really approached this with a spirit of collaboration. They couldn't do this alone. We clearly, couldn't solve for this. This was a frustrating problem, but that was, I think, probably the biggest piece as well, was kind of that willingness to sort of partner around developing a really robust, the stuff around measurement-based care that Kristina mentioned is very important. They were, they were going to demonstrate that this was going to be effective. They weren't going to just give us some flashy sales deck, which doesn't go very far. So, and also there was the collaboration around sort of data sharing and the potential as well, I think we talked about, for research. We want to help, everyone get better care for eating disorders. The only way to do that is to engage in that sort of collaboration.
Yeah, it's been a really fantastic partnership. I mean, we met really truly before we started Equip. So I was running Project Heal, Aaron was back at UC San Diego, and I had a call with Martin because we were trying to think about, I kept banging my head against a wall at Project Heal, right? I started this company at 15 years old to raise money for people who couldn't afford treatment, started funding all these individuals and saw residential, it has a 50% relapse rate in the first year following treatment, gets higher in subsequent years. And frankly, seeing a lot of my friends who I was in treatment with over 15 years ago who are still cycling in and out of residential treatment cycles and have never been introduced to evidence-based care. But also knowing how hard it was to find good quality outpatient clinicians, to have them trained in evidence-based treatment, tracking outcomes, communicating with one another. I mean, if you can find one person, it's rare that you can find a whole team, and usually they're not on the same page. So there were all these issues, and we just started kind of talking about how do we build a better outpatient model of care. And, we talked, we were really on the same page. We had the same ideas. We were looking at the same research. And Martin, about 2 years ago, kind of said, you know what? It's going to be pretty hard for Optum to figure out how to get outpatient providers coordinated, trained in all the states and geographies. I think that if you build it, we will come. And we said we will we will do that. And here we are. It's been a really wonderful, true collaboration, true partnership. Because at the end of the day, we're on the same page, right? Unfortunately, a lot of the existing treatment paradigm has vilified the payers for not covering care. And the reality is, we want to cover care that works. And actually, if we give people holistic outpatient-based care that really treats their entire disease and is focused on, we want to be incentivized by getting people better, it's actually more affordable for the payers as well. And so I think the fact that we were on the same page really, really made this partnership a lot more fruitful.
I think the quote was, build it and we'll pay.
That sounds like an ideal partnership setup. Aaron, Martin alluded to something earlier, measurement-based care, which I know is important to Optum. Can you talk a little bit about Equip's approach to clinical outcomes?
Yes, this is kind of my favorite soapbox. We need to differentiate between care that feels good and care that actually works. And one of my big fears, and something that we see every day, is that you can go to a therapist or a residential or anything for PTSD, for substance use, for an eating disorder, and you're going to get care that feels good, because really nice people go into the mental health field, and they're going to be good listeners, and they're going to be validating, and they're going to make you feel good, at least for that moment. And so you're going to leave treatment with them thinking, that was great, I really enjoyed that. But that's not the same as you stopping having nightmares and PTSD, or you being able to maintain your sobriety, or you recovering from an eating disorder. And unfortunately, in our culture, when you don't recover from a mental health disorder, you don't blame that really nice therapist that you've been talking to. You blame yourself, and you think, I'm too broken to recover. My PTSD is too severe. My eating disorder is too severe. When in reality, you were just never given evidence-based treatment. And so I think we all need to start differentiating between treatment that feels good and treatment that actually works. And payers should demand it and companies should provide it. So when we're thinking about outcomes, we're certainly thinking about satisfaction, but just a little bit, because oftentimes treatment that works feels kind of crummy, at least in the beginning, and certainly for eating disorders. We're holding up a lot of mirrors to the parents. Parents don't cause eating disorders, but they might be accidentally reinforcing it at times. Those are tough conversations to have. Satisfaction might not be all that high at the beginning of eating disorder treatment, but you have to keep it high enough that people stay engaged. So we certainly measure satisfaction, but the next we're measuring engagement. You need to be engaged in order to deliver the evidence-based treatment. So how do we keep people engaged? There's a great kind of meme going around right now about how in COVID, with all this virtual telehealth, therapists have been giving treatment just to foreheads, the teenagers' foreheads, because they, aren't using Zoom right. So we teach people, you can't just take treatment that you used to give in person and throw it on Zoom. That doesn't work. You have to take what's great about virtual care and do it a little bit differently. It gives you an opportunity to say, like, hey, take your laptop or your phone. I want to see your bedroom. I want to see what's in your pantry. I want to see what's in your fridge. You get to know so much more about people because you're truly in their homes with them virtually. And then lastly, after you've measured satisfaction and you've measured engagement, then you definitely need to be measuring efficacy. Not just is it working right now, but is it continuing to work when they're done with treatment? For most mental health disorders, most will start in adolescence, and we do treat children and adolescents and young adults. You don't want them relapsing. You don't want another depressive episode. You don't want their PTSD coming back, and you certainly don't want their eating disorder and substance use coming back. So when measuring efficacy, you have to, as a company, spend that extra time and do that extra work to make sure not only is it working now, their symptoms are going down, their engagement with life is going up, but then you also have to measure the patients that are no longer in your care. You have to care about how are they doing long after they've left treatment. And I'm happy to say that at Equip, they're doing quite well, better than we even imagined that they're doing. Some people have asked kind of why it is. We had this one patient who had been ill for 5 years, gained 0 pounds in 5 years, and she gained 10 pounds in her first 4 weeks at Equip. And so we talked with her parents and we talked with her and we're like, why is that? Like, why are you getting better? And they said they're like, first of all, we're not enjoying it. They wanted us all to know that neither the parents nor the child, they're like, we're not enjoying this. This has been a really horrible 4 weeks for us. But for the first time, we are all on the same page. We know what we need to do. We know how to do it. And the confusion of, all mental health disorders really gets taken away when you have a unified team. You don't have a dietitian telling you to gain 5 pounds and a therapist telling you to gain 20 and a pediatrician telling you it's just a phase. When everyone's on the same page, it helps people recover. So we're having good outcomes and we're pretty proud of it.
That is so important. Erin, you alluded to the pandemic. Kristina, perhaps you can weigh in on this one. I saw you recently wrote about how eating disorder recovery has evolved in the time of COVID-19. Can you talk about what risks or challenges have impacted this population?
Yeah, we've seen, unfortunately, what the New York Times called last week an explosion of eating disorders in the COVID-19 pandemic. And I think, unfortunately, we won't see the full repercussions for a number of years, but suffice it to say, Stanford Inpatient Unit is our #1 referral source right now. Their outpatient program for eating disorders has an 8-month wait list. And that is the same at the very few places that treat eating disorders across the country. And you have to think about eating disorders have the second highest mortality rate of all mental illnesses. So 8-month wait list, people can literally lose their lives in that time if they're not able to access treatment. So I think that's one of the things that we see that's tremendously scary. COVID's also been, it's been across the board mental health increases, especially for adolescents. And we talk a lot about sort of the temperament traits that enable one to be vulnerable to an eating disorder. It tends to be the type A, high achieving, perfectionistic kids who frankly might have used to pour a lot of time and energy and attention into school and sports and activities that they've had. Now in COVID, have channeled all of that energy into, not gaining the COVID-15 or fixing their bodies. And we've definitely seen the negative repercussions of that. In addition to food insecurity. So we touched on this a little bit. Unfortunately, a lot more families are experiencing food insecurity as people lose their jobs and lose their livelihood. And we know that as the level of food insecurity in a community rises, the levels of eating disorders directly rise with it. And this is one of the things that we're really, really optimistic about our ability to do with EQIP. Unfortunately, most folks with eating disorders weren't getting care. Certainly under-resourced communities, food insecure communities, Medicaid communities had little to no access to good quality eating disorder treatment. And we're really excited to go in and be able to provide those good resources to these families and also really educate that, we typically go into sales calls with Medicaid payers, and the first thing they'll say is, this isn't our population. We don't have these individuals. And by the end of the conversation, they're in a really different place. So I think we've been grateful that we get to serve this educational initiative to be able to say, look, these communities are impacted with eating disorders. We have a solution. It's cheaper than what you're originally paying, and it'll get folks way better. And they've been excited to partner with us in that effort.
Yeah, unsurprisingly, the pandemic did not impact individuals struggling with eating disorders very well. Martin, can you share some advice on how other payers can be more transformative in their approach to eating disorder care?
So I think, this has been a journey for us. And I think part of it is being able to sort of step outside the traditional model of just paying for sort of encounter-based care. So it's really working with some of these really innovative groups where they're willing to sort of take on a disease episode. And it's not just about bundled payments. I think it's really partnering well, with someone who has an innovative idea around what that means. So, it's sort of setting the limits, like how you're going to get the patient from point A to point B. Recognizing that a number of them will unfortunately have recurrence, but it's thinking about innovative, payment and how do you do that? I think the other piece is, from a innovator point of view, is recognize as a payer that we represent different channels or payment sources. So, that Medicare, for example, has certain restrictions from CMS. Medicaid has rules that may be set by a state. Even in the commercial space with large companies, recognize there's some limitations. And, I think from a payer point of view, you have to put those up front. We're not the evil empire. It's not that we want to say no, but there are some regulatory restrictions that, you need to understand and in terms of, working with a payer. And I think the third one as well, from a payer point of view, make this a partnership. Right? It's not just about what the provider can do for you. Think about what you can do for the provider. Can you share some data insights? Can you share some experience or sort of clinical expertise? Can you help one of these groups in terms of where they would locate, their sort of practice, where, we're sitting on reams of data around where the patients are, where the illness is. So, I know as a company, we did a lot with opiates around sort of helping some providers, and honestly, I think that's the key thing is, you've got to give to get and set it up like that.
This has been so spectacularly interesting and inspiring, amazing to see how your two organizations are working together to transform the eating disorder space, which has been in such dire need of transforming. I only wish we had more time. I'm just gonna wrap up with one last question for the EQIP team. If we could fast forward 5 years to 2026 and to think about what year is it actually, what does EQIP look like? What's your hope for change that you would like to see?
Well, Martin talks about the clarity of purpose, and I have to agree that that's one of our strong suits. And so really the mission is the same, to ensure that every single person with an eating disorder has access to gold standard treatment. We are sprinting as fast as we can. We have such high demand from families. We have families, it's horrifying to say this, but who are moving across state lines to get care with us, which is the opposite of why we started this virtual treatment program to enable families to get better at home. And so we're working as quickly as we can to get into all 50 states, to expand to adults beyond the age of 24, to be in network with, many, many more insurance plans, Medicaid, Medicare, commercial, and really to ensure that everyone is able to access this gold standard care so that everyone can reach recovery, because I want to leave everyone with the fact that full recovery from an eating disorder is absolutely possible.
Equip also hopes to continue to lead by example, and we hope that people take from what we're doing and realize that families need to be involved, whether it's for depression or trauma, and then also the importance of lived experience. This is something that Kristina has really pioneered. And then lastly, I'm hoping that we're getting a lot more sleep in 5 years.
Me too.
Well, as always, Kristina, Dr. Parks, you two are so inspiring, really wonderful to see all of this amazing progress since our last conversation. And Dr. Rosenzweig, thank you so much for joining and lending your expertise and sharing more about the partnership. Thank you both. Thank you all so much.
Thanks for having us.
Thank you.